When someone has a stroke, we tend to focus on the visible recovery, learning to walk again, to speak again. But what happens when the recovery journey is haunted by a new, invisible battle? We're talking about a chronic, relentless pain that can show up long after the initial event. It's called central post-stroke pain, and we're about to explore why the real source of the hurt isn't where you feel it at all.
So, let's start with a really mind-bending question to frame all of this. What if the agony you feel in your arm, or the burning in your leg, wasn't coming from your arm or your leg at all? What if it was actually a phantom signal, a kind of false alarm being generated by the very part of your brain that the stroke damaged? This is the fundamental mystery we need to unravel.
Okay, so picture this. You've survived a stroke. You're working hard, doing the rehab, focusing on getting your life back. And then something else starts. Weeks or maybe even months later, a strange and persistent pain shows up. And it's not the kind of pain you'd expect, like a sore muscle. No, this is something different, something deeper and way more confusing.
So what exactly is this? Well, the official term is central post-stroke pain, or CPSP. And the key thing to understand here is that this is pain caused directly by the stroke's damage to the brain's sensory wiring. Let me say that again. The problem isn't in the body part that hurts. The problem is a misfiring, a short circuit deep inside the brain itself.
Now you're probably wondering, how common is this? And well, here's where it gets tricky. The estimates are all over the place, suggesting it could affect anywhere from just 1% to a whopping 35% of stroke survivors. And that huge range tells you something really important. This condition is just incredibly difficult to diagnose.
And the pain itself? Man, it's not just one thing. People describe it in all these wild and awful ways. It can be a constant burning, like you're on fire, or a freezing sensation. It can be a deep, crushing ache, or these sudden, sharp electric jolts that just come out of nowhere. And maybe the cruelest part is something called allodynia, where a gentle touch, even the fabric of your shirt, can trigger an absolute explosion of pain.
So what in the world is happening inside the brain to cause all of this? How do the wires get so crossed that a light touch feels like a burn? Let's dive into the neuroscience behind it all.
Okay, one of the leading ideas is something called the disinhibition theory. And honestly, the best way to think about it is like this. Your brain has a natural braking system that keeps pain signals in check. A stroke can come in and basically just break that system. And when the brakes are gone, the pain signals can just run completely wild.
This diagram here really helps us see how that broken brake works. So a stroke can create a lesion, or an area of damage, in a part of the brain called the lateral thalamus. Think of that as snipping the brake line. It stops the normal, whoa, slow down, signals from working. And what happens? Another part, the medial thalamus, gets totally overactive. It's like it's slamming on the gas pedal for pain, sending out these alarm signals when there's absolutely no reason to.
Now, a second big piece of the puzzle is a concept called central sensitization. Here, the analogy is a smoke alarm that's just way too sensitive. You know, the kind that goes off when you're just making toast. After the stroke, the whole nervous system can get stuck on high alert, just totally hypersensitive to everything.
And we can see how this faulty alarm works on a chemical level. It's all about an imbalance. The stroke can flood the system with go, 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 go excitatory signals, while at the same time reducing the stop signals. This makes the neurons hyper-excitable. They get so jumpy that they start firing off pain signals all on their own, spontaneously creating the feeling of pain out of thin air.
So with a problem that's so complex and literally happening inside the brain's wiring, you can imagine that actually diagnosing it is a huge challenge. It's not like a broken bone you can just see on an X-ray. This pain is completely invisible.
In fact, CPSP is what doctors call a diagnosis of exclusion. And that means exactly what it sounds like. Doctors have to become detectives. They have to methodically rule out every other possible cause for the pain before they can finally appoint a CPSP.
And to solve this mystery, they have to piece together all these different clues. First, they look at the patient's story. When did the pain start? Was it after the stroke? That's a huge clue. Then they do sensory exams and often find that the area that hurts also feels numb or has other weird sensations. And finally, they look at brain scans, like an MRI, to see if the location of the stroke damage lines up with the brain's known pain pathways. It's a real puzzle.
So, once that diagnosis is finally made, the next, even bigger challenge begins, trying to find some relief. And because the pain starts in the brain, your typical painkillers often don't even touch it. So doctors have to get creative and use a whole different strategy to try and calm that storm.
Yeah, there is no single magic bullet for this. As you can kind of see from this overview, managing CPSP is a layered approach. It's about combining different types of medications and, for the really tough cases, moving on to more advanced therapies that work directly on the brain.
Now, the medication journey is really interesting. The first thing doctors often try isn't a painkiller at all. It's actually certain types of antidepressants. That sounds weird, but these drugs are really good at helping the brain rebalance its own pain control chemicals. If that doesn't work, the next step is often anticonvulsants. Yep, drugs used for seizures. Why? Because they're designed to calm down overactive neurons, which is exactly the problem here. Only after trying those do they consider things like opioids.
And when the drugs just aren't cutting it, doctors can turn to something called neurostimulation. You've got non-invasive options, which use powerful magnets on the outside of the head to gently sort of retune the brain's activity. And then, for the most severe, treatment-resistant pain, there are invasive therapies like deep brain stimulation, where they surgically implant tiny electrodes to go right to the source and block those faulty pain signals.
Now, while all these treatments offer real hope, the truth is many people still struggle to find relief. And that's what's driving this intense push in research to understand what's really going on, and it's opening up some incredibly exciting new ideas for the future.
This quote here points to a really big shift in thinking. For a long time, everyone focused only on what was happening in the brain, but now scientists are wondering about the signals coming from the body to the brain. The idea is maybe it's this constant stream of normal sensory information that's actually keeping that faulty pain alarm in the brain ringing. It's a game changer because it suggests we could quiet the brain by first calming the signals from the body.
And this new way of thinking is opening up a whole new playbook. Instead of just trying to silence neurons, the new targets are things like neuroinflammation, the brain's own immune response after the stroke. Scientists are looking at how to modulate the brain's immune cells, or how to block specific receptors and inflammatory molecules that get out of whack. The hope is to stop the nervous system from getting so hypersensitive in the first place.
So this all brings us to a really powerful final thought. As we get better and better at mapping out exactly how the brain responds to an injury, like a stroke, are we getting closer to a future where we don't just mask the pain, but where we can actually learn to go in and rewrite the faulty signals, to untangle those crossed wires, and finally silence the hidden aftermath of a stroke for good?